So I've been asked to talk about, as you heard, chronic inflammatory disease, and I think this is a very interesting topic. I don't know that we necessarily have the answers on how to manage these patients, but I'll show you what the data is and what we think so far. My disclosures are the same as have been shown before. So to frame this, we've been talking all along about the benefits, the cardiovascular benefits of LDL reduction, and I think we feel very, very strongly that that is really the target that we should be looking at, and that there is this clear association with reduction in LDL and improvement in cardiovascular events. And what I'm showing here is what you've seen many, many times, the CTT meta-analysis plus Improve It plotted on there. But there is this other angle, right? We do know that from a lot of basic and clinical work that inflammatory pathway contributes to development and recurrence of atherosclerotic cardiovascular disease, that there are a number of different mechanisms by which inflammation drives vascular disease, endothelial dysfunction, atherosclerosis. And so the question really is it all through lipid biology, or is there something independent with inflammation that we need to think about? And so that really led Paul Ritker to propose this question of, yes, of course, we're very convinced that there is this cholesterol risk, and there is this residual cholesterol risk, which we've been talking about all along, which is if somebody still has elevated lipids, that they are still at risk for cardiovascular events, and we want to treat those lipids to reduce that residual cholesterol risk. But is there also something to a residual inflammatory risk? So somebody who has well-controlled lipids, so for example, an LDL of 45, but has evidence of ongoing background inflammation, and in this example here, I have a CRP of 3.8 milligrams per deciliter, so very high. And is there any evidence that we should be trying to drive down inflammation as well as simultaneously trying to drive down cholesterol? So that's really the sort of residual inflammatory and cholesterol question. And so this is a slide which I've taken from Paul Ritker to say, well, we have a lot of data, and I will show you this, about what statins and ezetimibe do in terms of LDL lowering and inflammation lowering. So we don't think, I should say, that CRP is a risk factor. Rather, we think it's a risk marker for underlying disease. You can't drive, if you have mutations in CRP that alter CRP levels, that doesn't translate to a reduction in cardiovascular events. So it's just a risk marker, not a risk factor, but nevertheless, it's a good risk marker. So I'll tell you a little bit about what we know about statins and ezetimibe, and then the question really is we know, as you are all well aware, that statins improve cardiovascular events, reduce the cardiovascular events, and ezetimibe does too. But those drugs affect both inflammation and cholesterol, and how can we try to tease that apart and say what is really important? Are these independent pathways that are important? And so then where we looked was to agents that didn't have effect on the other pathways. So for example, PCSK9 inhibitors don't actually alter levels of inflammation. CRP is not changed by a PCSK9 inhibitor, but yet you've seen they profoundly reduce LDL. And so the question is that cardiovascular benefit then purely related to the LDL reducing with those agents? And then with other anti-inflammatories like canakinumab, as was studied in the CANTOS trial, that doesn't impact LDL. It reduces CRP, and it improved cardiovascular events. And so there does appear to be this sort of independence of these pathways. And then the final question that I'll address is, so say with PCSK9 inhibitors, you take LDL down to some very, very low level. Is inflammation important in that setting? So you really drive the LDL down low. Does it matter if you have residual inflammation? And so that's another question. So this story started with an analysis by Paul of the Prove It trial, where he said, let's look at different targets. Let's look at LDL targets, let's look at CRP targets, and people who attain either very low levels of LDL or CRP or both. And when you look at these patients in the Prove It trial and say, if I can get down to very low levels of LDL and CRP, and sort of even extremely low CRP here, those patients fared the best. And so it seems as if, and those who had either a low LDL or a low CRP sort of had equivalent risk for recurrent cardiovascular events. So there does seem to be, in an observational way, an association of achieving both of these endpoints in terms of reducing cardiovascular risk. We did the same analysis in Improve It, so with the addition of ezetimibe. Ezetimibe also reduces CRP, so both reduces LDL and CRP as well as statins. And in this case, we got the exact same answer, which is that when we looked at patients who achieved both low LDL and CRP, those individuals had the lowest recurrent event rates. So it was a very consistent story with what we had seen with Improve It. And then comes the more pure test, right? We've got a drug that only impacts inflammation, canakinumab, which is an IL-1 beta inhibitor, which, as you see here, reduces CRP, does not impact LDL. And in that setting, there was a cardiovascular benefit, so a 15% reduction in cardiovascular events. And when you look at the group of patients who started out with a lower cholesterol, you still saw the same benefit. So there was no heterogeneity there. So it seemed, in the absence of changing the LDL, that a reduction in inflammation was in fact beneficial. So that's one side of the story. And then the other side, which you guys know very well, is what if we reduce LDL and we don't affect CRP, which is the PCSK9 inhibitor story. And as you guys know, that clearly improves cardiovascular events. And so it does appear that both of these are important pathways to consider. Now, we've talked about risk enhancers before. What we did look at in Fourier is we said, okay, well, what if you have an elevated, either a nicely controlled CRP, intermediate or high level, what was your risk for recurrent cardiovascular events? And you see that risk increases with higher CRP, both for the primary endpoint and then for MACE. And then what was the benefit in terms of adding evolocumab in those various subgroups? And what you can see is that there was a consistent effect across those subgroups. But again, I don't know if I have it built in here. Yeah, I did. Okay, but again, the same concept of higher risk, higher absolute risk reduction in those people who have the most evidence of chronic inflammation in the background. But I think the question that I asked earlier is one that was still out there for us, which is, what about when we drive LDL down to extremely low levels? Does inflammation still matter? And so we actually had in Fourier, we had a huge number of patients. You can see 2,700 patients who got to an LDL less than 20 milligrams per deciliter at 1 month. And then we stratified by whether they had a CRP of 1 to 3 or greater than 3. And you see that CRP, even in those patients who have very low LDL, actually appears to be, again, a marker of recurrent risk. And so I think that the conclusion here is that we now have good, solid, randomized control data, obviously, to support the cholesterol axis. CANTOS supports the inflammatory axis as something to consider. We have this observational data, which I've just shown you, that residual inflammation is important even in the setting of good lipid control. And so this really supports the notion that we probably should be thinking about the inflammatory pathway and how we can target that. Now, practically how we do that, that's the challenge. So, for example, I'm sure canakinumab is not available for use for you guys in these patient populations that we've been talking about. So instead, it's our classic risk factor modification, things that can reduce inflammation in the background. So that's weight loss, smoking cessation, exercise. All of those will drive down your CRP and will reduce your residual inflammatory risk. And then, although I haven't spoken to specific inflammatory conditions, managing those patients, whether that's rheumatoid arthritis or some other inflammatory process, can also be helpful, we believe, in the background of somebody who has atherosclerotic cardiovascular disease. So with that, I will end my talk. Thank you very much.